I'd like to welcome everyone to the 2023 NNLM Virtual Symposium on Health Misinformation. We are glad you're able to join us today. Just a few technical items to cover before we get started. All attendees have been muted upon entry, but we do welcome your questions and comments in Zoom at any time. NNLM staff will be keeping an eye on the chat with me during the event. Please be sure to use everyone from the drop-down menu when posting your questions and comments in chat to ensure that everyone sees them. If you have questions for the speakers, please use the Q&A function to ensure they do not get lost in chat, and we will be reading through those at the end of the presentation. We do have live closed captioners for this event, and you can access the closed captions by clicking on the icon with the 3 dots and then selecting closed captions. If you would like to share on social media, we encourage you to use the hashtag for the event, HealthMisinfo NNLM. A few words about who we are for those of you who might not be familiar with us. The National Institutes of Health is the nation's leading medical research agency. Many of you might be more familiar with the National Center for Allergies and Infectious Diseases, which is one of the many institutes and centers at NIH. NLM, or the National Library of Medicine, is one of the 27 institutes and offices of the National Institutes of Health. It is the world's largest biomedical library and produces online resources such as PubMed and Medline Plus. NNLM, or the Network of the National Library of Medicine, is an outreach program of NLM, and it works to ensure health professionals and the public have equal access to health information. NNLM is made up of 7 regional medical libraries, 3 national offices, 4 national centers, all of which provide training, funding, and engagement opportunities to our over 9,000 member organizations. Ooh, I don't think my PowerPoint's in. All right, a little welcome for day 3. So good morning and welcome to day 3 of the Health Misinformation Symposium. I hope you have found the previous 2 days presentations informative and thought-provoking, and that you have had the opportunity to connect with others who are passionate about combating health misinformation. My name is Bobby Newman. My pronouns are she, her, and hers. I am the Community Engagement and Outreach Specialist at the Network of National Library of Medicine, Region 6 office at the University of Iowa. And I am the chair of the organizing committee for this event. Today, we will focus on strategies for addressing health misinformation and empowering individuals to make informed decisions about their health. As we have seen throughout the symposium, health misinformation is a complex issue that requires a multifaceted approach. One strategy for addressing health misinformation is through digital literacy initiatives. And as we've heard over the last 2 days of the symposium, the internet and social media have played a significant role in the spread of health misinformation. Digital literacy initiatives can help individuals become more critical consumers of health information online by providing them with the skills and knowledge to evaluate the accuracy and reliability of sources. Another strategy is fact-checking resources. Fact-checking initiatives can help debunk health misinformation and provide accurate information to the public. As we have heard, fact-checking is not always a straightforward process, and it requires a nuanced approach that considers the potential harms of spreading false information. However, when done correctly, fact-checking can be an effective tool for promoting accurate health misinformation. Librarians, researchers, epidemiologists, public health professionals, and medical professionals all have an essential role in combating health misinformation. As trusted sources of information, they can provide access to reliable health information and help individuals navigate the complex landscape of online health information. Additionally, libraries can partner with community organizations to promote health literacy and provide accurate health information to underserved communities. Another strategy for combating misinformation is collaboration. As we've heard over the last 2 days of the symposium, health misinformation is a complex issue that requires a multidisciplinary approach. Collaboration between healthcare professionals, researchers, librarians, and other stakeholders is crucial for developing effective strategies for addressing health misinformation. Finally, we must also consider the role of health literacy in empowering individuals to make informed decisions about their health. Health literacy involves the ability to understand health information and the ability to access and use that information to make informed decisions. Improving health literacy can help reduce the impact of health misinformation by enabling individuals to distinguish between accurate and inaccurate health information. I hope that today's sessions will provide you with valuable insights and tools that you can take back to your work in tackling health misinformation. By working together and leveraging the resources available, we can make a difference in promoting accurate health information and empowering individuals to make informed decisions about their health. And with that, I would like to introduce today's keynote speakers. Catherine Arnott Smith is a professor at the Information School at the University of Wisconsin-Madison, and she will be leading the presentation today. Amanda J. Wilson is a Deputy Associate Director for Library Operations at the National Library of Medicine. And Alla Keselman is the Acting Chief of the Office of Engagement and Training at the National Library of Medicine. And unfortunately, she is traveling and not able to join us today. And together, they were the co-editors of Combating Online Health Misinformation, a Professional's Guide to Helping the Public. With that, I'm going to stop sharing my screen. Catherine can share her screen and begin her presentation.
Good morning and welcome to our keynote. I'm Catherine Arnott Smith, like you just heard. I'm going to be presenting content written by me, but also by my colleagues, Dr. Keselman and Ms. Amanda Wilson. Amanda is virtually in the room and she's going to be fielding questions at the close of the presentation. So here we go. The objectives of our talk today are to discuss markers of health information quality that librarians and others can use, review some factors that may affect susceptibility to misinformation, present programs that are combating health misinformation, and finally make recommendations for professionals who promote evidence-based health information and wrangle with misinformation.
Hey, Catherine, I'm sorry to interrupt you, but we are not seeing your slides. Do you want to try sharing your screen again? Okay.
Sorry, it's telling me I'm sharing.
Yep, we can see them now. And if you just want to start your presentation, yep, there we go.
Sorry. I have done this before.
Oh, it wouldn't be a presentation without a technical glitch.
So the first bit is me, and I'm talking about those quality markers with the tag phrase, let the reader and viewer beware. Let me give you an example. The overview of what I'm talking about begins with an example of one program of health information evaluation around the corner from me in my city, Madison, Wisconsin, talking about the origins, where these quality markers came from, going from print to digital, some proposed solutions that involve quality markers, and finally, the challenges of quality markers. So there's a nonprofit called Wisconsin Health Literacy, which is one of 70 community-based literacy programs just in this one state. We have a range of services through Wisconsin Health Literacy. They go from customized workshops to full-day training sessions and 3-day retreats. And there's a Midwest Large Health Literacy Summit Conference is how they bill it every year. And all these programs focus on digital health literacy and train people to think about 5.5 critical questions, which are these. Who's providing information? Why did they create the website you're looking at? Do they want personal information? If so, what will they do with it? Who is paying for the website? And is the information up to date? So yeah, the challenges posed by COVID-19 for health literacy are new challenges, but the importance of evaluation in a health information environment has been recognized for at least a century. And in fact, the evaluative benchmarks and standards and quality metrics and skills that are currently taught by organizations like Wisconsin Health Literacy originated in that world of print. To understand medical information in print, we need to turn to the librarians. So a common misconception you see in the literature on healthcare is that public interest in health topics began with the web, and that before that time, the physician was the patient's principal source of medical information. But in fact, one very important location for medical information has always been the public library. The public library was by definition going to be more open to consumers and patients, but also open in a way that didn't require either physician intervention or physician interpretation. So the reader's most important relationship was an invisible one. It was a relationship with the librarian who selected the material the patron found on the shelf. So the selection criteria in libraries were originally developed not for library users, but for the library workers, the professionals who decide how best to meet the needs of those users now and in the future. Selection decisions have a big impact beyond the user, though. So in the world of print, the librarian is selecting not just for individuals, but also for the communities and the contexts in which these users live. And as every librarian knows, understanding the user group, the community in which the individual information seeker is working, is almost as important as understanding the individual seeker's need for the information. So the librarian who selects has to think about more than one user at the same time. So what quality criteria were necessary in the world of print to determine what was acceptable when it came to health information in library collections? So selection criteria first got articulated in the 1930s, and they were then handed down in classrooms through textbooks in the field of library science for decades and decades. So what you're seeing on the screen is the book selection policies for Baltimore's Enoch Pratt Free Library, compiled in 1963 for this library, which was an important pioneer in making health information available to the public. And selectors for medical books were told to consider these things: author, physical characteristics and format, the scope, the subject, the style, the publisher, sources, and target audience. So compare those selection criteria with those from this classic textbook for collection management in general for everybody, published in 1995. Format, scope, relation to similar works, like is the work unique? Authority, which is authorship and publisher and sponsor and all that stuff. And treatment, which covers tone, accuracy, objectivity, what audience is it for? So at this point, health information moves online. And in 1995, something else happened. An important librarian at Iowa State named Jerry McKiernan explicitly translated the ALA's classic quality criteria, which had evolved from the 30s, to the internet for his pioneering CyberStax. CyberStax was an internet-based virtual reference library developed in 1995, 3 years before the Google guys developed Google. And CyberStax was a way of organizing health websites. CyberStack's original criteria for website selection, not print book selection, are going to look pretty familiar at this point in the presentation. Authority of the source, accuracy of information, clarity of presentation, uniqueness within the total collection, even in web terms, recency or timeliness, and favorable reviews. So let's think about what has really changed when it comes to quality markers when information moves online from print. The original filters for bad information in print were human beings. First, the editors, the publishers, the reviewers, then post-publication, the librarians and other information intermediaries, ensuring that factually problematic material doesn't make it onto the shelf. Authorship, attribution, disclosure of financial relationships, currency, those are all qualities that are used as benchmarks and proxies for quality control that was previously exerted during all the stages of the print production process. So evaluators of online health information have a difficult task. They are attempting to understand and describe post-published content that is in a digital shelf instantly on the shelf. This means that health information evaluation online is going to have unique challenges right from the beginning. And quality criteria for health information on the web first gets articulated in 1997 in an article by Silberg et al. That appeared in the Journal of the American Medical Association. And I will note that all the citations for this presentation are on a document which I uploaded into cyberspace, and it's somewhere on your site, but I don't know where. The authors wrote, in this 1997 piece that these standards weren't complicated. Authorship, which meant authors, their affiliations, their credentials. Attribution, do they provide references? What are the sources? Disclosure, things like advertising policy and sponsorship. And currency, how timely is the content on the site? Just those four things. And the authors said websites that fail to meet at least these basic standards should be considered suspect. And elsewhere in the same paper, the problem is not too little information, but too much. Vast chunks of it, incomplete, misleading, or inaccurate, and not only in the medical arena. The net, and especially the web, has the potential to become the world's largest vanity press. This said in 1997. So as of April 2023, what have we got in terms of solutions, in terms of evaluation criteria online at the moment? They fall into four basic categories: principles and codes of conduct, checklists and scoring instruments, quality labels and trust marks, and gateways and quality filters. And these solutions, mind you, are going to overlap because you can deploy standards in different ways using different tools. So principles and codes of conduct, a good example, which unfortunately expired in December of 2022, was one of the longest running sets of principles for web information evaluation. And it came from the Health on the Net, or ON Foundation. It was a nonprofit organization based in Geneva, Switzerland, organized by physicians from around the world who became concerned at the explosion of misinformation online. The ON Foundation promulgated its 8 principles in 1995. And the 8 ethical principles establish that a good website that you can trust is authoritative. It achieves complementarity between physician and patient, which means that the physician-patient relationship is supported by the website, respects privacy, attributes sources, supports treatments, products, and services with justifiability, observes transparency, practices financial disclosure of things like corporate sponsors, and has an advertising policy. And another example is the criteria I talked about on the previous slide. Here they are again. The article by Silberg et al. Got turned into a kind of evaluation instrument of its own, cited 1,081 times in Web of Science as of late March of this year, precisely because they got turned into a set of quality principles for developers to use in developing websites. So then we have the category of checklist or scoring instrument, and these are interesting because they're quality markers the user puts into action for themselves, as opposed to principles that are built into the information resource by the architects. And there are lots of checklists. One systematic review done in 2019 found 14 different tools used in 153 published studies. Discern, though, is one of the longest lived and most published about checklists there is. Discern was developed at Oxford University in 1996 by a multifaceted group of stakeholders as a partnership between the British Library and the UK's National Health Service. And unusual for the time, Discern was designed by people that included stakeholders, patients, as well as healthcare providers, and it was always intended for use by patients. The Discern questionnaire has 15 items about criteria that range from how clear is the website's presentation to the risks and benefits of the treatment that the website's talking about. Now, it's important to understand Discern was designed specifically for text, not anything else like videos, and it's only intended to be used to rate online information about treatments, nothing else. Then there's the quality label or trust mark. Yes, it's the Health on the Net Foundation again. The terms quality label and trust mark, or kite mark in some countries, all give the idea of a seal of approval. So the long-lived OnCode. Websites that voluntarily asserted they were following those Health on the Net quality principles got awarded an OnCode seal by volunteer reviewers, and more than 8,000 websites use that OnCode seal since its beginnings in 1995. This long-lived seal of approval is no more, which doesn't mean that others will not arise to take its place. And finally, we have the category of a trusted web gateway or filter. This is a website that is a curated place to contain only links to websites that have been vetted according to selection criteria. And those criteria are ideally transparent, so the user can decide whether the user's values and the values of the gateway keepers are in sync with each other. One of the longest living examples of such a gateway is the National Library of Medicine's Medline Plus, which was released on October 22nd, 1998, explicitly targeting a consumer readership. So the challenges of evaluation in this space are pretty constant, and one big one, of course, is who evaluates. Because evaluation places strains on human resources. Humans themselves, of course, are sources of bias. How does one even know that one has asked the right humans to evaluate? Then there's what gets evaluated exactly. In health information evaluation research, which is copious at this point, content about Western scientific medicine in the form of text in published journal articles or on web pages has typically been the default object of study. How about complementary and alternative medicine? How about non-scientifically based medicine? How about pseudoscientific medicine? And how about quackery? Non-text has also received a lot less attention in the research. All the instruments I've discussed in this presentation were developed for evaluating text. So this limits how much you can generalize evaluation results to things like YouTube videos. However, there's a growing cottage industry of YouTube video evaluations for the purpose of understanding what patients are seeing in YouTube and how much it matters. Finally, what instruments get used to evaluate? As I've tried to convey in this presentation, there are quite a few instruments to choose from. Since the instrument is your data collection mechanism to understand your population, what you collect will matter for what you infer about your population and about the information it's encountering online. So the biggest problem for evaluators, which showed up very early in the web's evolution, was the popularity of evaluation as a research topic, because a lot of people recognized evaluation as really important in their specialty. This meant scores of instruments got developed for each specialty. And different clinical domains have different assessment instruments now based on the priorities and the patient populations of those domains. So you get a health information explosion, you get a matching explosion of instruments to measure that information, which all guarantees you've got multiple assessment instruments competing for attention in the same space. So it became very difficult to make comparisons between studies of health information quality, and no single gold standard has ever been able to evolve. Then finally, the biggest challenge, in my opinion, is the brutal reality, especially when it comes to understanding misinformation online. A very important feature of medical information is simply not measurable. Standards and codes and checklists and instruments are all encoding values about information. But those tools can't fulfill individual users' information needs in a critical domain, and that's the domain of accuracy. No instrument currently available attempts to approach the idea of accuracy for the simple reason that you can't establish accuracy in a contextual vacuum. So what happens is quality criteria turn into proxies for likely accuracy. So the Discern project at Oxford makes the reason for the problem with accuracy clear, both in its handbook and on its website. Discern cannot be used to assess the scientific quality or accuracy of the evidence on which a publication is based, as this would require checking against other sources. So concerns about medical information are going to recur reliably at points in human history when medical content is being made widely available to an audience other than the audience for which it was written in the first place. And checklists and all these other quality assessing methods represent attempts by specialists in different fields to solve the problem. By empowering consumers to understand quality criteria as proxies for credibility, health literacy trainers in and out of libraries are hoping to bridge the gap between consumer expertise and the expertise reflected in the content those consumers want. And this is the reason that librarians and patient educators have to focus on training consumers to recognize these long-standing, well-tested, but proxy markers of quality online. So here's a photo credit for you telling you that was a picture of the Newberry Library's medical reading room. And a note that the references for this, as well as Amanda Wilson's presentation, are available through electronic handout in the conference space. So this next presentation was created by my colleague Alla Keselman, Health Misinformation Online and Competencies that People Need to Deal with It. So as the title of the slide states, misinformation is, of course, a very big problem. During the past few years, the COVID-19 pandemic had a devastating effect on the world. It changed many aspects of our lives. While the development of vaccines eventually softened the effect, many people remain suspicious about the vaccines, and a rampant spread of misinformation played a role in feeding vaccine skepticism. Just like the spread of the disease itself, the spread of misinformation about the disease became a global phenomenon. And an illustration on this slide comes from a chapter that anthropologist Alexandra Arkhipova wrote for our recent book, Combating Online Health Information, A Professional's Guide to Helping the Public. This is the dialogue that Dr. Arkhipova overheard in a Moscow grocery store in September 2021, and I'll read it for you. Don't get vaccinated. Why? They put Lucifer's gene inside it. Everybody who got the vaccine starts to hate God. Better stay home and drink more hot tea. This is a good prevention against COVID. This illustration is striking because it comprises many characteristics of misinformation and mistrust that I'll talk about in the remainder of this presentation. So it's a very old problem, as well as a big problem. We can trace misinformation back as far as there is human history to trace, but the historical example I'd like to describe now is from the early 1900s. In the 18th and 19th centuries, traveling salespeople in the US and in Europe touted medicines they promoted as cures for all illnesses, and some of these medicines contained or claimed to contain snake oil as one of their ingredients. One such medicine in the US became particularly infamous through the notorious case of Clark Stanley, who built a commercial empire producing Clark Stanley's snake oil liniment. Stanley claimed that his liniment was a near magical cure that could rid sufferers of a wide range of ailments, headaches and arthritis to cancer and even blindness. As the times started changing, in 1906, the US government enacted the Pure Food and Drug Act. And in 1916, Clark Stanley was investigated and exposed as a fraud. An investigation showed that the liniment actually had little or no snake oil. Stanley had to pay a fine, but he died a wealthy man, although with his reputation tarnished. Today in the US, we've got regulation of drugs, but foods, including supplements, are not. And the problem of health misinformation and promotion of cures that make unsustainable promises still persists. So although the problem's old, it's acquiring disconcerting new characteristics, and its flames are being fueled by new technologies. Information technology brings us many tremendous advantages when it comes to health. Unfortunately, technology also makes misinformation easy to create and easy to spread in a variety of formats. Curation of information that was present in traditional print media is no longer there. Anyone with a smartphone can create a short video about curing cancer in 3 minutes via the power of positive thinking and upload it to YouTube, to TikTok, or both. Sharing this information with a large network is also much easier than it used to be. So what do we know about health misinformation online? Well, while much of online health information is of high quality, research studies show that misinformation is more likely to be shared. A study by Bash et al. Found that the most popular vaccine-related YouTube videos are anti-vax, which means that viewers are much more likely to give thumbs up to anti-vax than to pro-vaccine videos. In another study, researchers found most of the top social media stories about Zika in 2018 were misinformation or rumors. In certain situations, people might be more likely to share misinformation than high quality information, and there may be several reasons for this. Misinformation is often shinier and more attractive than accurate information. It looks more newsworthy. It often simplifies complex issues. It makes sensational promises. So it also looks more sharing worthy. In some cases, misinformation is also likely to dominate internet search results. This happens when, in their queries, individuals may use search terms that bring misinformation to the top. For example, when they search for natural reversal of conditions that are incurable. In our own study of analysis of results from a web query of diabetes reversal natural, we found that of the top 24 searches, most of them promised full recovery from diabetes within a short time window. I hope that by now I've made a convincing case that in a technologically connected world, the information ecosystem will always be characterized by breadth and complexity, with misinformation always being part of it. With this, let's switch our attention from characteristics of misinformation to individual factors that may affect user susceptibility to misinformation. On this slide, we have 6 factors identified as contributors to this susceptibility in the research literature, and I'll consider them in turn. The first one is information literacy, which has been defined as a set of aptitudes to locate, handle, evaluate, and use information efficiently for a wide variety of purposes, generating competent citizens who are better able to perform their activities in the new society. Information literacy includes the ability to locate and evaluate information and pay attention to factors like what was the authority of the source that produced it? Is there a conflict of interest? What is the date that the information was created? How do the authors treat their evidence? Plus, information literacy involves the skills you need to design and modify a good query. It's also knowing what to do if you're in doubt about the accuracy of a claim, and knowing what to do may involve going to fact-checking sites like Snopes.com. According to Snopes.com, CERN, which is the European Council for Popular Research, did not open a portal to another dimension in July 2022. Then there's science literacy, the second important factor affecting susceptibility to health misinformation. Science literacy is the sum of our experiences with science. It's a complex concept with 3 components, each of which may affect how people evaluate health-related claims. The idea of science literacy originates in the field of science education, and its concern about how science should be taught to future non-scientists. We'll consider the 3 components of science literacy in turn. First component, knowledge of science. The knowledge of scientific facts, of concepts and models. This is what makes up the content of most of our science textbooks. Knowledge of science is important. In order to understand how vaccination works, for example, one needs to have some basic understanding of viruses and the immune system. Imagine someone who doesn't know how molecules create bonds. For that person, the explanation, vaccines work by introducing antigens that trigger B cells to produce antibodies that bind to antigens, that won't make sense. However, many studies show that knowledge of science alone isn't sufficient for making effective health decisions. The example on this slide comes from a podcast episode recording a conversation with both parties' permission between a respected community physician in rural Tennessee and his patient who was hesitant to receive COVID vaccination in May 2021. The physician asked the patient, who's a retired engineer in his 70s, about his greatest vaccination-related concern, and the patient's concerned about the possible presence of microchips in the vaccine. The doctor responds by pointing out, when you get the injection, it comes with a needle that's got an opening about that wide. We don't make microchips that small. When you have a dog, it gets microchipped, for example. There's surgery done, right? They don't inject it into a dog. To this, the patient admitted that he was familiar with microchips and the doctor's argument made sense, but this knowledge was not sufficient to sway this retired engineer into wanting to receive the vaccine. There are several reasons why knowledge-based explanations may not be sufficient. In some cases, people may not be swayed by them because they have insufficient science knowledge to understand the biological mechanisms. In other people, the mechanism, like the mechanism of a drug action, may be too complex or too uncertain. Yet in others, like in the example above, trust, identity, and emotional factors take prevalence over biological explanation. The second component of science literacy is knowledge about science, which is the understanding of science as a process. Knowledge about science refers to understanding just what constitutes a scientific question. How does science go about deriving the answer? The checks and balances, for example, control of variables and peer review that exist to minimize bias and reduce errors. Knowledge about science is a potentially promising competency that hopefully leads to understanding that when it comes to ways to generate knowledge, science, while it's imperfect, has powerful advantages, such as built-in ways to control against bias and self-correct. It's also likely to make one skeptical about some statements that claim to be supported by science but are not. So what's on this slide comes from an online article about circumcision permanently altering the brain. Alla writes that she encountered this article in her social media feed. The alleged author describes a so-called study that he supposedly conducted to prove this. To do the study, he supposedly convinced a friend of his who was an MRI machine operator to put an infant on whom the circumcision was performed into an MRI machine for the procedure in order to record the infant's brain waves. Now, it is not actually possible to perform circumcision on an infant inside an MRI machine, but this is not the only red flag in this article. Had this study been conducted, it would have been a terrible study that could not have produced reliable results, as it only involved one participant. In addition, no institutional review board would have approved this study protocol. So, knowledge about science could make one skeptical about the study and hesitant to share the link to it, regardless of one's views about the practice of circumcision. The third component of science literacy is attitudes towards science and scientists. This component relates to knowledge about science. Attitudes towards science have to do with perception about the nature of science and its ability to generate knowledge about reality. This is an attitude that may be damaged by oversimplified representation of science in the K-12 science education curriculum. When complexity and uncertainty aren't addressed, people may start out by viewing science as all-knowing and all-powerful, and then quickly become disillusioned and seek answers elsewhere. We saw some of this during the pandemic, when the public reacted to controversies over recommendations at different points in the process with unease. There's also trust in scientists that stems from a perception of what their intentions are and which goals they serve. A little more on trust. Individuals and communities will differ in their trust because of their different attitudes towards the stakeholders and the actors of the scientific process, such as the government that funds research and the health professionals who often carry out biomedical research. These differences are grounded in different sociocultural experiences. As we know, for some communities, the historic narrative is that of being ignored, mistreated, or used in research studies that cause them harm. I'm sure you're all familiar with the United States Public Health Service syphilis study that continued observing the progression of the disease in African American men after a cure was developed. That study was done by the U.S. Public Health Service. It's had a long-lasting impact on the perception of federally funded research and public health initiatives in African American communities. It takes a lot of effort to rebuild trust. Other factors known to affect information choices and resulting beliefs are ideology and religion. When scientific issues become politicized, scientific beliefs become about identity, and people go to great lengths to protect their identity. I talked earlier about the importance of seeking out information that supports identity protective beliefs. This graph shows how for politicized issues, ideology is stronger than science knowledge. On the left side, we have the prediction of how science competence would impact beliefs about the statement, global warming is mostly due to human activity, if science literacy worked independently of ideology. In this case, for both liberals and conservatives, we would expect a correlation between their science literacy and an understanding of the human contribution to climate. But this is not what in fact happens. For conservatives, as their exposure to science education and science knowledge increases, so too does their skepticism about the impact of human activity on global warming. On this particular issue, science exposure increases entrenchment. The science of climate change is very complex. The internet has plenty to offer to those who want to find information to protect their beliefs. To conclude, I want to show a few examples of how the factors I just presented affect reaction to various myth debunking statements. This slide is a snapshot of a CDC webpage that presents and attempts to debunk several COVID-19 myths and promote vaccination. Let's take just two myths. COVID-19 vaccines contain microchips, and COVID-19 vaccines can alter my DNA. But the first one, the CDC explains COVID-19 vaccines don't change or interact with the DNA in any way by describing the biological mechanism of vaccine action. The explanation, even though it attempts to use simple language, is conceptually complex, and it makes references to mRNA and DNA, cell nucleus, and vector viruses. Understanding all this requires knowledge of biology that is rather sophisticated. Also, even for someone with a high level of biological knowledge, the statement, the vector virus does not have the machinery needed to integrate its genetic material into our DNA, is not simply plausible because of its internal logic. It requires trust, too. The other myth gets debunked by a simple statement that the vaccines do not contain microchips. COVID-19 vaccines do not contain microchips. Vaccines are developed to fight against disease and are not administered to track your movement. This isn't really an explanation. And this statement doesn't present evidence either, but it's hard to do much better than this because proving a negative is hard. Yet accepting what the CDC correctly labels as fact requires trusting the CDC. If someone isn't inclined to trust science or the CDC, this webpage will not work well for them. We finally got to the so what part of this presentation. What do we take from all this? A few things. About communicating with the public about science. First, in doing this, it's important to recognize and acknowledge science isn't perfect. Neither are scientists. It's also crucial to promote an understanding that uncertainty and complexity are inherent parts of science. Specifically, biomedical science and health are domains that are very, very complex. At the same time, we have to stress uncertainty doesn't mean that all views are equally valid. Information professionals should foster understanding of the mechanisms that make science self-correcting, conspiracy-resistant, and a preferred way of building knowledge about the natural world. It's also important to address the difference between legitimate dissent and denialism. Legitimate dissent involves critical thinking and examination of sources of evidence. Denialism is skepticism motivated by ideology, relying on rhetorical tactics rather than on the scientific method. Another important way to support the public, fostering information literacy as it pertains to science and health medical questions. Information professionals can support the public's engagement with science and scientists. People trust those with whom they have relationships, so sparking dialogue between communities helps engender trust. Most importantly, we should always be respectful and understand that every health decision involves subjective value components. Accurate interpretation of the same high-quality information will still lead different individuals to different behavioral preferences, and that's okay. A few takeaways about health communication. Same as with science communication, building relationships characterized by mutual trust is critical. When it comes to building relationships, there are no shortcuts. This takes time, commitment, and concerted effort. Relationship building needs to be happening continuously and with persistence, not just at the time of public health crisis. Last, certainly not least, it is important to exercise cultural humility and listen respectfully. Listen to people's concerns and needs, understand their circumstances and their cultural practices, and build the conversation around those. Thank you.
Wonderful. Thank you so much, Catherine. We have, it looks like about 30 minutes for question and answer. So if people have questions, please go ahead and use the Q&A function to submit those questions to make sure we don't miss them in the chat. You are also welcome to talk amongst yourselves in the chat.
You know what, Bobby? There's one left. I've still got Amanda Wilson's to give. That's all right. I was just about to click the slide. Okay, this is me again, presenting the work of Amanda Wilson. Ms. Wilson is the Deputy Associate Director for Library Operations at the National Library of Medicine, and before that, she worked with Alla Keselman in NLM's Office of Engagement and Training. And her presentation is about combating online misinformation by addressing susceptibility and safeguards. So in my own talk earlier, I mentioned those quality markers, checklists, principles, quality labels, gateways. And from Alla Keselman's presentation, we take away these ideas that an individual's susceptibility to online health information is influenced by the individual's information literacy, science literacy, attitude towards authorities, political ideology, religious beliefs, and sociocultural experiences. With that refresher, Amanda's presentation is focusing on 5 example projects and activities addressing all or a subset of quality or susceptibility factors. So first, consider a discussion paper published in 2021 by Kington et al. Again, the references are in that handout. This was about identifying credible sources of health information in social media, principles and attributes, and it came from the National Academies. This paper really hits all the marks we've covered today. Its focus is on the role of social media platforms supporting the public in evaluating sources of health information through a set of recommendations intended to inform policy. And the principles and attributes of credible sources of information laid out in that paper were that the source is science-based, it strives for objectivity, and it provides transparency and accountability around its policies and processes. The flowchart on the slide shows the recommended assessment process for credibility. Social media platforms might take these steps when providing and elevating credible sources for consumers. In case you can't read this well, the 4 steps are written as questions, and they are these. Is the source a nonprofit or government organization? Is the source subject to a pre-existing standardized vetting mechanism? Does the source demonstrate alignment with the author's scientific principles and a preponderance of credibility attributes? And finally, has the information shared by the source passed some form of content review by a social media platform or an independent third party? You'll note that in working through these questions, the recommended evaluation process guides social media platforms in assessment that centers those foundational principles and attributes of credible sources. Going back to the focus of this session, embedded in each of the white box steps are approaches that address all the quality marker proposed solutions, depending on the source being evaluated. In terms of the factors addressing susceptibility to health misinformation, this source assessment process addresses science literacy and attitudes towards authorities. The team on this paper also recognized, as we all do, that the misinformation problem is multidimensional and complex. And in recognition of that, several parallel strategies were also discussed, one of which was health literacy, culturally competent communication, and community relationships. I call this out because the strategies here cover the other susceptibility factors. Specifically for social media platforms, that means investing in evidence-based health literacy and consumer education strategies to support the success of their in-house approaches to elevating credible sources and high-quality information, doing that or through their third-party delegates doing this work. For organizational sources of information, that means they should, quote, strive to be credible sources of health information and should invest in strategies to improve their communication skills by using languages and images that are informed by cultural context as well as understandable and engaging. At the same time, they must share complete and precise information and avoid oversimplification. They should also seek to build authentic collaborative relationships at the community level, unquote. Second example, informed health choices. They do primary school resources for 10 to 12-year-olds, and they were developed through cycles of prototyping, pilot testing, and feedback from children, teachers, and other stakeholders in Uganda, Kenya, Rwanda, and Norway. I highlight this example because even though the resources were developed and launched just before the pandemic, the infodemic only underscored and made more urgent the needs for these types of tools to equip consumers to reject misinformation. So informed health choices develop key concepts in 3 categories as educational interventions for consumers to evaluate health information. And these concepts are standards for judgment or principles for evaluating the trustworthiness of health information. The 3 categories for their concepts are claims, comparisons, and choices. A claim could be treatments may be harmful. A comparison example would be, if possible, people should not know which of the treatments being compared they are receiving. And an example of choice is decisions about treatments should not be based on considering only their benefits. IHC's critical thinking approach addresses several factors that make individuals susceptible to misinformation. The approach covers both information and science literacy, both of which are essential for individuals to be able to assess evidence and apply knowledge to inform behaviors. The approach also addresses the susceptibility factor of sociocultural experiences. In their development work, IHC did expect there'd be a need for additional adjustments to content to make it suitable for use in other languages, cultural settings, and educational environments. The team developed detailed, pragmatic, open access guidance for translating and contextualizing the resources with an emphasis on how to engage students, teachers, and other key stakeholders in the work. And really, this tailoring could also bring in an account for other susceptibilities, including attitudes towards authorities, political ideology, and religious beliefs. The next 2 projects move us into the patient-provider relationship, where in these interactions between patients and providers, online medical misinformation will often arise. First is the IMPACT project out of Illinois. The IMPACT model considers these examples where medical misinformation can arise in the patient-provider relationship. Pseudoscience, which they define as misinformation due to unscientific claims. Outdated science. Due to the incremental nature of science, information is now outdated or has been reversed. Junk science. Claims made based on fraudulent or disproven data. Inappropriately applied science. Misinformation due to clinical heterogeneity, which renders science not relevant to the clinical context. And finally, conflicting interpretations of science. Misinformation that's perpetuated because there's conflicts between two or more established guidelines sometimes. Of course, patients can be exposed to this information in any setting, including through online resources. Impact is a nonprofit coalition of physicians and health professionals who are working to identify and meet the needs of Illinois' healthcare workers and communities. They engage grassroots networks, they advocate for evidence-based solutions, they advise influential stakeholders, and they amplify solutions protecting the individuals and communities across the state and across the country. They explicitly focus on engaging online, and the sampling of infographics on this screen gives you a sense of the work they produce to distribute via social media outlets. The group's social media presence, on the slide is Facebook and Instagram, positions their outputs and activities to promote quality markers discussed earlier in this talk and to address susceptibilities to misinformation. So from the examples on the previous slide on their website, as a credible source, they outline their principles and they elevate other sources they trust. Their philosophy for engaging online addresses all of the susceptibility factors. It includes focusing on reaching individuals who are unsure just which information they should believe. Lead with the facts, that are statements and claims grounded in evidence, informed by respected experts in the field. In a reactive response to misinformation posted, they suggest summarizing the key points and screenshotting the important parts of the article that should be read. Their proactive approach is team-based, and again, it's demonstrated by those infographics on the previous slide, demonstrating that a proactive, targeted, coordinated strategy can be undertaken with easy-to-understand social media posts, infographics, and messaging to quickly and rapidly stop myths from spreading further. Partnering with other organizations and trusted community messengers, this counter messaging can be amplified and circulated beyond one's reach. Lead from where you stand. Consider a personal anecdote or perspective. I'll also take a moment to call out the Alaska Public Health Information Response Team, which has a similar model, and I've got places to find more information about the Alaska one in the references too. Continuing with this theme of healthcare providers addressing misinformation presented by patients, the Duke program on medical information takes on the provider side of the equation. This program aims to build the patient-provider relationship in a way that encourages psychologically safe conversations about all types of medical information, regardless of accuracy. The theory is that through supportive interpersonal dialogue, providers and patients can work together to avoid the pitfalls of misinformation. The program discusses the patient's challenge by medical misinformation, how it impacts the clinical encounter, and the lack of preparation and training that healthcare providers receive to discuss such misinformation with their patients. Other academic medical institutions can use Duke as a model or a supplement to potentially mitigate the spread of medical misinformation. There's three main challenges to address: time constraints, the prevalence of misinformation, and training imbalance. In terms of time constraints, contact time is scarce and valuable, and both the provider and the patient must choose what is most important for discussion in the clinical setting. If patients opt to refer to inaccurate information found online, which they don't recognize to be inaccurate, part of the challenge lies in the time that's available to explore and discuss the misinformation. Time constraints are also relevant in telehealth visits, and because of their suppressive effect. If patients perceive that time is lacking during a clinic visit, they may choose to withhold information about the supplements they're taking or the prescribed medication that they have decided not to take. The prevalence of misinformation, the near ubiquity of encounters with medical misinformation is its own challenge and the subject of this symposium. Then there's a training imbalance. In addition to extensive training in the basic science of the body, how to interpret clinical data, vital signs, lab analysis, scans, etc., and skills that relate to that patient encounter, healthcare providers also typically receive training in shared decision-making. But ideally, training would also produce provider-patient interactions that not only maintain strength and trust in that relationship, but also remove potential blinders that providers might have given their other extensive training. So this training for providers addresses susceptibilities patients may have to misinformation. My last example comes full circle to where we started looking to libraries, and the perspective for this is that of NLM's Office of Engagement and Training, or OET, which serves as a connector linking NLM and NIH biomedical and health information to their users. And in its work and its programs, OET particularly emphasizes engaging populations and communities that are medically underserved and or experiencing health disparities, as well as professionals who serve them. One of OET's main programs is the network of the NLM, or NNLM. OET is a main driver in NLM Library Operations 2036 long-range plan goal, know and equitably engage our users. So in keeping with that thread of equity through engagement, I'm highlighting one approach OET is investing in for their programs, specifically how libraries can help advance critical health literacy in their communities to combat health misinformation. Critical health literacy is a process in which community members become aware of issues, participate in critical dialogue, and become involved in decision-making for health. For us, it provides a framework for libraries to engage communities more equitably, inclusively, and collaboratively in order to build online misinformation resilience over the long term. Using community-informed approaches through the lenses of inclusion and equity can provide libraries with the tools to work meaningfully with communities, an active response to mis- and disinformation and its resulting impact on health outcomes. In that mode of building critical health literacy through community engagement for library staff, activities, and library programs, this slide represents a few examples and actions librarians can take. Ideally, these actions will help libraries effectively equip their communities with skills and strategies to evaluate the quality of health information resources. Effectiveness is, of course, measured by the activities and programs' ability to address susceptibility factors across their diverse user base. I encourage you to find the NNLM region that covers where you are in the US and reach out to partner through funding, training, or other engagement opportunities. Improving health literacy is a goal for the program. Combating health misinformation is a priority. I appreciate your time and attention. References and resources, again, were uploaded to the virtual space somewhere. I'll note again, many of the examples talked about came from your keynote speaker's recent book on combating online health misinformation. Much more about the activities are detailed there. As a final example of libraries writ large engaging with a key competency in combating misinformation, I should mention the Federal Information Literacy Task Force, which was announced by the Institute of Museum and Library Services in September 2022. It's convening an interagency task force over the next year, and it includes agencies that address public uncertainty, lack of understanding, that are innovative in communicating with the public, and that build capacity at the local level. With that, thank you one more time. This is Amanda Wilson's contact information, and I'm going to hand it over to Amanda to field those questions and discussion. And now, Bobby, I really am done.
Great. Thank you so much, Catherine and Amanda, for being here today. Wonderful presentations. And I do see that we have some questions coming in the Q&A. So I'm just going to read those out, and then I guess Amanda will be answering those. So I think this is, well, it is a question. So I wish that schools would focus more on teaching children things like science literacy, how to analyze information online and determine misinformation. In an era of them growing up with social media and readily available information online, this is even more important. Are there any public schools / public library partnerships or programs that focus on this?
Thank you for the question. Thank you, Bobby. Thank you, Kat, for pulling together our presentation and presenting it today. This is a really great question, and I noticed in the chat that there had been some initial responses. Someone linked to a link about Illinois high schools who are required to teach media literacy. I'll also respond in the Q&A. The CDC had a list of resources for schools, K-12 schools, to teach health literacy, which does include some information for libraries. I'm really interested in the attendees here if they have any examples, any additional examples of specific public school and public library partnerships around health literacy. I'm sure that's something that the NNLM, your local regional medical library, might be interested in funding if you have ideas in your neighborhood. And also, just as Kat just finished up talking about that Federal Information Literacy Task Force, I'm actually on that task force, and this is something to go into our discussions as we come up with our final deliverables and output of a website and whatever else we're going to be doing at the end of this year, looking at that intersection between schools and libraries and supporting all facets of information literacy, of which health literacy is one of them.
Great, thank you, Amanda. I also want to remind everyone that there are exhibit booths that are unstaffed that have links to a wide variety of resources from NLM, NNLM, and NIH. So you can check out there for tools for combating health misinformation. I'm not seeing any more relevant questions come in, but we'll give it a couple more minutes. I like your background, Amanda.
Thank you. It is the year of open science, everyone.
Oh, okay, all right, yes.
Wonderful. Seeing some links in the chat, seeing some additional examples. Thanks, folks. Queens Public Library, Web, Lit, Legit. Bobby, I also thought that was there anything, I saw someone mention the Association of School Librarians, and I wondered if through any of the work of the Public Library Association and their health literacy initiative, if there are any connections with schools there.
I am not familiar with any off the top of my head. I can reach out to a couple of people I know that are involved, like in Yalza as well, and see if they have any resources specifically for that. I see another question we've got come in. Let's see. For clarification, the IMLS grant-funded task force goal is to work with U.S. federal government agencies to better present messages to the public. Is it broader? So I think you talked about that in one of the presentations.
Sure. The task force goal is to help address misinformation through providing an information literacy tools for the public to use. And that's me paraphrasing. So Sally, if you'll just give me one moment, I will actually pull up our charge so I can actually read that directly. And it's always so much fun to watch people look things up.
And someone's asking about the handout that is on for the presentation. It is on the conference website next to the description for this program. So you should be able to access a PDF of it if you go there. Let me see if I can link directly to the PDF if it will work. That rather inelegant link hopefully will take you there.
Thank you, Bobby. And to come back to Sally's question, from the Consolidated Appropriations Act of 2022, IMLS was asked to create an information literacy task force tasked with developing guidance instructional materials, and national strategies on information literacy. So that's our general goal. Specifically, there was a call for a website, and it said that the website shall serve as a clearinghouse for information on literacy programs, offer strategies and tools for native and non-native English speakers, and coordinate information across the federal government. So I will copy and paste this into the chat in case anyone is interested in the charge of the task force and reading that legislation.
Great, thank you. Another question I'm seeing in chat, do you know if any of these groups like Impact work with patient advocates who often have the trust of the large communities that follow them?
So for Impact, yes, they did discuss their partners who they work with. And in many of the examples that we've seen, many of the strategies were working with affected communities and embedding with other organizations. Many of these are volunteer activities, so getting those people who are already motivated to support and engage, including students as well as community organizations, were important strategies in the sustainability of those projects. Thank you, Kat, for posting that. I apparently can use.
And I also want to remind everyone that Web Lit Legit was funded by Region 3 of the NNLM. So do reach out to your regional office for funding opportunities. I'm going to put that link in the chat here in a second. Oh, somebody else has done it. Thank you, Margot. Right. Any other questions for our presenters?
Hey, Sally, I'm seeing the follow-up. I did just try to drop the link directly, and you're saying how great it would be for a program to teach those from federal agencies who give public updates on science and help instruction on how to do this more effectively. Thank you for that, Sally. I will take that back in our next deliberations and incorporate that in our discussion. So thank you for that feedback. Aaron, yes, I remember you. Hi.
Lots of thank yous. Catherine, I saw you said someone asked one, but I cannot find it in the chat, unfortunately.
Amanda, do you see it? Let me read it. Elaine Cox says, I have folks say they don't trust the doctors or hospitals because both get, quote, incentives, unquote, for prescribing certain medications. I cannot say this is misinformation because I have no idea about any of this. What do we do in these situations? Ugh, that's a hard one. What do you think, Amanda?
That is gnarly. That is gnarly. Yes. So in that situation, my first would be to point people to information resources like Medline Plus or any of those other kind of trusted resources that Catherine talked about that have those quality markers to help them to find at least some trusted information upon which hopefully they can compare with what they've heard from their providers to maybe try to come to their own determinations. But yes, I think the next step would be pointing people to a collection of trusted information to help them to build their own knowledge and compare that to what they're hearing from their physicians or healthcare providers. Kat, would you have anything to add to that?
No, I think the problem is it takes time for a deeper conversation. That's part of the time constraints. And yeah, I always try to figure out exactly what the person's problem is. And if you get them kind of to dig into exactly where they are feeling nervous, sometimes that helps you point out at one of those external resources. But finding, yes, there absolutely are. Sean Corning is saying, yep, there are real instances. I mean, there's bad actors out there everywhere in every profession, and we aren't going to get rid of those folks. So I think the trick is to figure out what meet the patron where they are and actually come up with some example of information from a source they've indicated they trust. You're not going to be able to change their minds in a 15-minute clinic appointment, right? So
yeah, I think, Kat, that addressed Elaine's follow-up, sort of breaking through the distrust, and you're
yep.
talking about kind of finding where that is. And yes, Sally, the underlying aspect, so much founded on for-profit and in our society currently is a challenge.
Yeah, that's absolutely right. The occasional bad apple does. Unfortunately, sometimes it's the bad apples we remember. But I find that oddly enough, I have this happen as an educator every so often in a class, and I try to flip it around and say, what evidence would you trust? Who do you trust? And I find that kind of mantra of like turning it around and asking them to express, to look at themselves and see what in fact they would trust. Sometimes that helps.
And kind of building on that, it reminds me of the National Institutes of Health is investing in supporting community engagement networks and building community engagement networks. It's a program called Compass. And we're accepting applications now, but the idea is that, yeah, you might not trust the physicians, but if we can provide trusted intermediaries, trusted messengers and communities with good health information, that might be another way to either break through the distrust or go around it, because there could be other avenues in communities to get access to health information. And so I'll try to find the link for the Compass program, but that is something that, especially as we've learned through COVID and the response to COVID and looking at the public's trust in the government, one thing that we need to invest more in is community engagement and supporting other community partners. Thank you so much, Stephanie, for dropping that link in the chat.
I don't know if you saw, there's a question in the Q&A. Is it considered misinformation when studies don't or aren't able to publish all of the data and the studies only publish a sliver of results?
Is that considered misinformation? I think part of maybe some of the question behind that would be the intent. If the sliver of the results doesn't present the totality or is presented to only show one side of or a particular answer, then I would say yes, that kind of goes behind the intent. So from that perspective, I would say yes. Kat, do you have?
Yeah, I agree. I mean, it kind of slides over into misrepresentation of results if you're only giving one little piece of the pie and the rest of the pie is online and you have to dig for it. Yeah, sort of, it gets down to what did they mean when they did that. Journals don't always let you publish everything. So, everything may be massive reams of paper if you printed it out. So even when it's digital, you aren't often able to publish everything authors would like to publish.
I'm scrolling up, and I'm sorry if we're missing things in the chat. I saw a question and I lost it. About, are there any thoughts on how we make it attractive for social media platforms to make suggested changes? Right now, the incentives for them point the other way. I will say that that's something that I will take back to the discussion of the information task in general. I'll also point to the resource from the National Academies for social media platforms to be able to point out trusted health information. And that was actually funded and done in partnership with some of the larger platforms. But efforts like that could continue to help, or at least provide a pathway for social media platforms to do it. But in terms of incentivizing and the right levers for that incentivization, I think is something that's ripe for discussion, especially with the task force.
So just as a wrap up for this session, I want to thank Amanda and Catherine for being here, and Alla, who wasn't able to make it but contributed to both slides and the book. If you are interested in claiming MLA CE credit for this session and others, we will be sharing the link for that in the final session today. You will also receive an email after the symposium with the questionnaire and instructions to claim that CE. We have about 30 minutes until our next session, which starts at 1:30 p.m. Eastern time. We encourage you to visit the booths. The exhibits that we have set up are not staffed. No one is going to bother you. And it includes a wide variety of resources from NLM, NNLM, and NIH on combating health misinformation. We also encourage you to get away from your computer, move, stretch, get a drink, and maybe go outside if you can. So thank you everyone for your time and attention, and we'll see you in about a half an hour.